So good morning, good afternoon, and good evening to all the audiences around the world. And thank you for joining our ACNS ISMINS webinars today. So today our chair is Professor Zhifeng, who is the Department of Neurosurgery of the Huashan Hospital, University of Shanghai, China. And for the speakers of today, our first speakers is Professor Hiroki Toda, who is the Program Director of the Department of Neurosurgery of Medical Research Institute, Kitano Hospital. He'll be talking about the exoscopic microvascular decompression. Our second speakers of today is Dr. Sai Kalyan, who is the Senior Consultant Neurosurgeon of the Institute of Brain and Spine Services, AGI Hospital in India. His topic is navigation in spine. Is it a game changer in spine surgeries? So for the discussion of today, we have Professor Dushot, who is a neurosurgeon and the secretary of the Uzbekistan Association of Neurosurgeons, the Republican Specialized Scientific and Practical Center of Neurosurgery in Tashkent in Uzbekistan. Our second discussion, Professor who is the head at the Senior Consultant Neurosurgeon and the Department of the Department of Neurosurgery, Tunku Hospital, Kuala Lumpur, in the Department of Pediatric Neurosurgery, Hospital Tunku Asias Women and Children Hospital, Kuala Lumpur. He's also the head of the Neurosurgical Service Ministry of Health in Malaysia. To moderate the section with us, we have Dr. Teague, Zhifeng, and also Dr. Piswas. So without further delay, shall I hand over to the podium to our first speakers, Professor Toda.
All right, thank you very much for your kind introduction. My name is Hiroki Toda from Osaka, Japan. I'm a functional neurosurgeon and also doing the microvascular decompression for hemifacial spasm, trigeminal neuralgia, and also glossopharyngeal neuralgia patients. So let me share my presentation. Okay. The video is okay?
Yes.
Yeah. So,
Yes,
okay. So I'm very honored to have this wonderful opportunity, and I'd like to thank Professor Kato and all the meeting members for this ACNS and minimally invasive neurosurgery webinar series. Thank you very much. I have nothing to disclose for this presentation. So microvascular decompression has been the standard surgical treatment since the 1970s. Its fundamental principles are simple and well established, as elegantly illustrated by Professor McLaughlin and Peter Janetta. Successful performance of the procedure, however, requires a precise visualization of the intricate neurovascular complex and cerebropontine angle. And the relatively new surgical tool, the Exoscope, offers an ideal solution to meet this requirement. So I have listed the role of visualization in microvascular decompression in a stepwise manner. So Rero Sigmund approach provides an optimal surgical window that allows for careful dissection of the venous system and identification of neurovascular conflicts. Dissecting the offending vessels requires a precise discrimination between the arachnoid membrane, perforating arteries, and small veins. Mobilization of the offending vessels then demands a delicate manipulation to avoid compromising the surrounding microcirculation. So after exposure of the left lateral subluxal bone, in this case, and the inferior nuchal lines are identified, and a small bone flap is removed, and the limited dural incision allows for early CSF release. And subsequently, we will add a bone removal to expose the sigmoid sinus further. Okay. And show the right trigeminal neuralgia case to explain further outline of the surgical steps. In this case, SCA and trigeminal cerebral artery contact the trigeminal nerve. So the arachnoid cuff around the superior petrous vein is now incised, and the SCA is exposed and observed through the space between the vein, dura, and the cerebrum. And the Rotund right angle dissector is used to gently mobilize the SCA while preserving its perforators. And as illustrated in the first pages, we pulled out the SCAs toward the lateral superior direction and cut the arachnoid between the SCA and trigeminal nerve, and completely mobilized the SCA toward to the along the tentorium, and we placed a small amount of fibrin glue, and then we moved to the horizontal fissure of the cerebrum to confirm the TCA, trigeminal cerebral artery, contacting to the trigeminal nerve. So this artery is a kind of small artery, and this ends the small perforating artery. So it's been a little dangerous to mobilize further. So we use the small PTFE fibers, and I use it and sling it onto the dural surface of the petrous bone, and I confirm the final view of the microvascular decompression in this case. So there are several key advantages to using the exoscope in microvascular decompression: the 3D 4K images and a wide FOV and a free angle viewing, and enhanced ergonomics for the surgeon and assistants. In addition to these 3 points, the system also integrates extensive machines such as electrophysiological monitoring. Such an integrated monitoring display can show the operative view and a brainstem auditive vector potential side by side, which can provide us prompt feedback for hearing preservation. And the surgical team engagement can also be enhanced by utilizing the multiple displays, including ceiling-mounted monitors, as well as individual head-mounted display for each team member. So these setup eliminate the limitation of relying on the fixed monitors in the operating room, so allowing us to share the same high-definition surgical view easily. And let me now move on the workflow in exoscopic MVD. The first consideration is the optimal placement of the exoscope when designing the OR setup. Initially, we placed the exoscope behind the surgeon. However, this arrangement presented difficulties in making fine adjustment to achieve the optimal trajectory during the operation. So learning from the experiences of several preceding groups, we subsequently adopted a setup with the exoscope placed in front of the surgeon, which has proven more effective. So this schematic illustrates the exoscope layout. The system is positioned in front of the patient face, allowing a direct and stable visualization trajectory. And this placement enables a precise fine adjustment of the camera angle, which is particularly advantageous when observing the root exit zone of the facial nerve. And the second consideration is the patient positioning. We transition from using a traditional lateral recumbent position to a supine or supine lateral position, particularly after introducing the exoscope. In this position, the patient's ipsilateral shoulder is elevated and the head is gently rotated toward the contralateral side, and the neck is flexed slightly, and the patient's head may be elevated to minimize the intraoperative venous and sinus pressure. Even a patient with a short neck like this, the adjustment provides sufficient working space and facilitates a favorable surgical trajectory. In addition, the monitor display is positioned approximately 1.5 meters from the surgeon to optimize the 3D effect. The height of the displays are also carefully adjusted to ensure comfortable posture and a proper stereoscopic viewing. After the setup is completed in each case, the surgical trajectory is confirmed and simulated in collaboration with the assistants and the primary surgeon. Especially in hemifacial spasm and glossopharyngeal neuralgia cases, the camera head is positioned just above the ipsilateral shoulder and oriented toward the external auditory meatus, thereby approximating the operative view of the CP angle from an inferior lateral perspective. So we will expect to review the 300 cases of exoscopic MVD. The surgical outcome will be presented following the description of a representative case. And this is a left hemisphere spasm case. A dural opening revealed a vertebral artery and accessory nerve. And we cut the arachnoid over these structures and also covering the glossopharyngeal nerve and pica and venous, vagal nerves. Gently retracting the choroidal plexus, then exposing the pica loop, compressing the root excision of the facial nerve. So vertebral artery is already adherent to the dural surface. We attempt to mobilize the pica loop from the downward direction. We sometimes use the bimanual manipulations and also pulling out the pica gently. But in this case, there's a multiple perforating artery and they are relatively short. So we decide to mobilize one by one. Just removing the small perforating artery along the pica and pulling this pica, but there's a small perforating artery, so we cut the arachnoid just along to the perforating artery, which might help the mobilization a little bit. But we finally observe the anterior inferior cerebral artery is compressing the facial nerve root there, and there's a compression by ICA and a demarcation over there. So we cut the arachnoid between them and using another PTFE fiber to mobilize the ICA and pushing the ICA into the medial direction using a small ball of a PTFE in this case. So after this procedure, we pull out the both side of the loop of the pica. So proximal part will be mobilized using a PTFE, and the distal part of the loop is also mobilized using a PTFE. And this is going to be the final view of the decompression. So let me explain a little bit about the prosthesis we use in these cases. According to a study by Professor Hasegawa and the MVD Society in Japan, the most commonly used prosthesis is a combination of PTFE and a fibrin glue, which allows the mobilized vessel to be fixed securely and achieves reliable decompression. So Professor Hasegawa's team made this PTFE product, CRAX. It's specially designed for microvascular decompression, and they used a small piece of it to create a ball thread and a ball-shaped cushion, which was illustrated in the previous cases. And we applied a fibrinogen solution to make this fibrin glue kit. This PTFE sling technique is also effective when the perforating arteries are very short, like this. This is demonstrated in another patient with a hemifacial spasm case. So in our exoscopic series, the outcomes do not differ significantly from those of our previous microscopic series, both in hemifacial spasm and trigeminal neuralgia patients. And our exoscopic series has a fewer transient facial and other cranial nerve dysfunction and has several non-severe adverse events. The slight difference between these two series may reflect the experiences of our surgical team. But this is a survey result from our surgeon and assistant who evaluated the image quality of each exoscopic case. So they consistently favor its high resolution and a depth perception and a wide field awareness. However, some surgeons, including me, late glare and flare control, in some cases poor in certain cases. And in such situation, we reduce the light intensity slightly to minimize the glare from an overall bright surgical field. So this case is going to remove this prosthesis was tentatively used, and it is going to be the final confirmation. We also evaluate the surgeon's ergonomics using the rapid upper limb assessment scale, which scores the position of the upper arm, lower arms, and wrist during the procedure. So compared with the same patient positioning under the microscope, this RULA scores are better when using the exoscope. So as a note of caution, significant pneumocephalus may develop after the cases, since the supine position may induce spontaneous and sometimes excessive CSF drainage. To prevent this potentially hazardous complication, we tilt the operating table to the contralateral side and slightly reduce the head-up position at the end of the procedure. And we fill the subdural space with ample artificial CSF just before tying the final dural sutures. And this maneuver effectively reduced the post-operative pneumocephalus. So in conclusion, the exoscope is a viable alternative to perform MVD, and it's not inferior to the operating microscope and offers several clinical and educational advantages. Successful application requires optimization of the operative layout and patient positioning. Surgeons should also be mindful of complications such as pneumocephalus, which can be mitigated by replacing lost CSF at the end of the procedure. So I'd like to conclude my talk by sincerely acknowledging my colleagues for their outstanding patient care and team organization. Thank you for your attention.
Right. Thank you so much, Professor Toda. It's really an impressive lectures. So shall I invite our discussion to short? Maybe can I invite you first to comment Professor Toda's lecture?
So thank you so much, Professor Toda. This is a very beautiful presentation and excellent results and very nice use of exoscope in the surgery of microvascular decompression. So what really interested me in this, how do you control the depth of the image? Do you regularly displace the exoscope's objective near and far from the patient's head, or this is some kind of automatic regulation inbuilt in the exoscope?
Yeah, it's very automatic, and we don't have to change the camera position when we're doing the same direction, I mean trajectory. So we can adjust slightly during the procedure, but once it started, we don't have to change the depths. It's like a distance between the patient's head and the camera.
So it goes focus
Yes.
in the depth structures automatically, yeah?
Yes, it's going to be automatic focused to in the center of the field, but you can also adjust the focus if you want to see the peripheral, like you just when you just need to observe the kind of two things, like the one thing in the center, one thing in the peripheral. You can adjust the focus by your foot pedal.
That's very nice. And the second question is it really reliable to the method of transpositioning using the threads PTFE, and you just use it with the fibrin glue? You just stick it to the dural edges or the tentorium or to the vessels, and it is safe enough to do so, and no need to other methods like interpositioning or stitching. Just fibrin glue is enough, yeah?
Well, I guess so. Well, in some cases, like a very tortuous vertebral artery, for example, we sometimes use the fibrin glue and the taco seal as other adhesive product for making more stronger adhesion to the dura. But yeah, most case PTFE and fibrin glue will be enough. I sometimes experience the recurrence of the cases since we started this technique, and we've just confirmed the original attachment is in the same place, and very adhesive. So I think that'll be kind of durable way to using the fibrin glue and PTFE.
Okay. And the last question is about the hemifacial spasm. Some, we have many cases when we do MVD with facial nerve. Maybe this is the method of a matter of touching the facial nerve itself. But after our surgeries, maybe like 60, not more, like 50 or 40% of cases, we have slight transient facial palsy. What's your statistics regarding that? Maybe we're doing something wrong. Yeah.
Well, yeah, well, of course, we experienced the transient facial palsy. It's going to be, I think, 2-3% of them. Yeah. And the permanent facial palsy is quite rare. I guess maybe some ischemic events or something wrong happened in those cases. So, well, for our group, the more problematic thing is the very slow healing of the hemifacial spasm. Like hemifacial spasm persists even we finish the complete decompression. So we use the electrophysiological monitoring of the facial muscles, and even after the complete mobilization, some patients had the abnormal muscle responses. So in such cases, we guess they're gonna eventually recover from the hemifacial spasm, but it takes time. So we just need to wait about at most 2 years after the surgery. Yeah.
Okay.
My experience.
Thank you. Thank you so much.
Thank you.
Just I want to tell the Dr. Dilshot that you said that after the hemifacial spasm surgery, that 40% of the facial palsy, you said.
Yes. Well, actually, we don't have
much.
many. Yes, it's too much. We don't have so much cases of facial hemifacial spasm, but after the surgery, it's like 3 or 4 patients out of 10, we have transient palsy. I think this is a matter of microvascular technique failure, maybe. We're touching the nerve maybe very hard. Maybe that's the reason. But I don't know why. This was the reason I'm asking. Yeah.
So my injuries are that yearly maybe over 150 cases, but very seldom facial palsy after the surgery. So maybe, Toda Sensei, do you have any suggestion for him or?
Well, I'm sure you're doing very well, and well, just a matter of the standard. So how you strictly judge your outcome? No. So well, as I told you, probably 2-3% of the transient facial palsy after that, but yeah. We need to check.
Yeah.
So maybe you insert or sometimes transposition.
We usually use interposition. Maybe that's the reason. Maybe. Yeah.
Maybe.
Most of the Chinese case is interposition. They never do the transposition. Yes. maybe you can send us, maybe you can show us a video the next time, please. Thank you.
Thank you.
Ben, please.
If I can ask one question.
Of course.
Yeah, this is to Dilshod. Like, do you do endoscopic or microscopic? Dilshod.
Basically microscopic.
Okay, because sometimes the very high intensity of the light can cause heat-induced
Oh.
transient palsy.
Oh, really?
Okay. That is, I have heard from several people who are doing endoscopy, going very near to the nerve, or doing operating at very high intensity, may cause some heat-induced damage. That is what my opinion is.
Okay, that's a good point.
Right.
And I ask a quick questions, Professor Toda. I saw that you the Micro Decompression Society, the research about the use of the exoscope. I think this, I think most of the neurosurgeon in Japan find that the exoscope image quality is very good. And personally, I think that it is also very good when I visit the GK University. I saw that you are using the same OP-I system. The OP-I system is actually have quite good quality, image quality, in my opinion, compared to the others blank of the exoscope. But unfortunately, I think that this OP-I system is not available. They are not exporting to certain parts of the world. I would like to ask about in your study of the society, have the neurosurgeon compared the different brands of the exoscopes concerning the image quality? And because I saw that you mentioned about the study of your society in your presentation.
Well, right now the surgeon who use the exoscope in our society is small. Like only a few groups are using the exoscope, I believe. Maybe now increasing, but by now the very small number of the surgeons use it. And basically all they use the exoscope from the Olympus. So you said all by. So I personally don't have the communication for using the other exoscope system.
Yes, I think the design of this system is quite good and have good image quality.
It's not expensive, so I mean comparing to the standard microscope, so quite I mean cost performance is very good.
Nice.
So in Japan, we have another company, it's Mitaka company.
Yes.
But I think OI is a much better quality, I think.
Oh,
But quality itself, comparing with the microscope, I think exoscope a bit less than the microscope. I think that is my opinion. Thanks.
Okay, thank you for your information.
Thank you. Shall I ask if there are any further questions from the forum? So if not, shall I invite Dr. Sai to present your presentation?
Yeah, hi Ben, am I audible?
Yes.
Yeah, I'll share this.
Yeah, just a moment. Professor Zhifeng has joined us shortly. So he's supposed, I just contacted him. He's supposed to be the chair of today, and he's sorry about to delay. Professor Xi, can you hear me?
Yes. Hi. Hi, Ben.
Yeah, hello.
Hi, Professor Kato. I'm sorry I mistake the time of Beijing time and the Japan time. I supposed to be there 8 p.m. Beijing time. Sorry to be late. Okay.
We have just completed Professor Toda's lecture about the exoscopic MVD. So we are about to talk about Professor Dr. Sai about his lecture in navigation in spine.
Yeah, I'm trying to share my screen. Yeah, Ben, am I audible?
Yes, you're audible.
Yeah. You're able to see the screen?
Yes.
We are seeing the next slides also below.
Is it so? 1 second. Is it okay now?
Yeah.
Maybe Dr. Sai, we cannot see your point so clearly.
Can you just turn your phone?
Oh.
Yeah.
Okay, that's much better.
Yes.
Is it okay, sir? Is this okay?
Yes, but still we can see the lower slides.
1 second. I'm going to remove this. Okay, is this okay?
We are seeing the slides on the left side. It's okay. Go on.
I think this should be fine now.
Okay, yeah.
So good afternoon, my mentor, Professor Kato, and dear friends. These are some of my memories in 2016 when I went to Japan. I visited Professor Kato and did my 3 months of fellowship in cerebrovascular surgery there, after which my perspective towards neurosurgery has changed a lot. And we had opportunity to felicitate her when she came to India in 2019. And when I expressed my interest towards spine, she recommended me to Professor Mehmet Zeleli, where I've learned the tricks and trade of minimally invasive spine surgery along with deformity. And this is the recent when we met Professor Kato in winter seminar in month of February 2025. So I am Dr. Sai Kalyan. I'm a senior consultant neurosurgeon in Institute of Neurosciences, AAG Hospitals, Gachibowli. So my areas of interest are cerebrovascular surgery. I do all simple and complex spine surgeries along with cranial and spinal endoscopy. So I work in this hospital, which is a 1100-bedded multi-specialty hospital. So let me tell you that after going through this presentation, let us all conclude if this topic, this name of this topic is reliable after this presentation. So how many of you are aware that one C-arm shoot produces almost 500 milliroentgen units? I humbly admit that I have done enough number of minimally invasive surgeries, minimally invasive spine surgeries under C-arm guidance. And I admit that I take minimum of 50 shoots, which is equal to around 5,000 milliroentgen units. It's not only for me, it is for the patient and the assistant surgeon and anesthetist who are 5 meters nearby the C-arm device. Whereas one OARM average exposure is around 4,000 milliroentgen units. That is for the patient. So there has always been myths and facts about this minimally invasive spine surgery. With the advent of imagiology, the spine surgery has evolved a lot. Initially, we used freehand techniques followed by 2D C-arm fluoroscopy, followed by 3D fluoroscopies with different generation of navigation systems. And now currently, the world is towards the robotics and AI. If we go back to history, Paul Huguet was the first person who has performed the surgeries using X-ray fluoroscopy in World War, where he used X-ray to remove the bullet of the patient. So what is a navigation system? It is nothing but, say, for example, if you want to go from Fujita Health University, Bantane Hospital to Fujita Health University, what we do, it helps us to know where we are, where we want to go, and a safe way to follow the route, that is the GPS. So the spinal navigation also works in the same system, but in the operation theater. So it is basically introduction of GPS to the operating system, where the satellite is something compared with the localizer, that is the camera, the tower with the patient's reference frame, and the navigation with the instruments. So there have been different systems like first generation systems, second generation systems. So in the first generation systems, they used to take a pre-op CT, they used to load that in the navigation system. And once the patient is kept in prone position and after exposing the bony landmarks like the spinous process, facet joints, spinolaminar lines, the surface matching was done. But the disadvantage of this procedure was there was always a surface mismatch. So this first generation navigation system didn't last long because of this inaccuracy and error in the results. The outcomes were not good. So then came the second generation fluoroscopy, which is cost effective. We get two views here, that is biplanar imaging. We don't have an axial views. It is definitely easy for if you're doing a one level T-lead surgeries, but not useful for patients who are obese and also in deformity cases. And next came the third generation system of navigation systems. So there are many available in market. In our institute, we have the OARM, and this OARM is nothing but an intraoperative CT scan. It provides 360 degrees, three-dimensional views. It permits a surgeon to obtain the immediate CT images after the completion of surgery as well, and it has the capability to obtain CT images with multi-cut reconstruction along with navigation. And the advantage of this is it has got less radiation when compared to CT scan. So what all we need is a navigation system, the image that is the OARM, and these images are fed to the working station. And unlike the Google, it is most of the time reliable. So these are the different instruments which we are supposed to be which we are supposed to have the familiarity. This is the this is the reference frame, the passive planar blunt in the middle, and right is the navigated Jamshidi, navigated Lenki saw, navigated tap, and navigated screwdriver. So what are the indications for this spinal navigation? We can do whatever, that is, all the pathologies can be addressed from C1, C2 to sacrum, both simple and complex. So what is the workflow? The workflow is like initially the rigid fixation system is the rigid fixation system is fixed to spinous process or a percutaneous spring to the iliac spine, and next the OARM 3D spin is acquired, followed by image acquisition and reformatting these images, and later the registration and calibration of the instruments. So this is how we do. We fix the reference frame. Later the navigation OARM navigation system is bought in. We take the 360 degrees, that is AP lateral at a 360 degree spin, and these images are transmitted to the navigation system. After the transmission of these images to the navigation system, what we do is we need to calibrate the instruments. Once the calibration of instruments is done, we start planning the trajectory of the screws, and we place the screws. So if you can see here, the trajectory is planned. Next, the length of the screw can be planned. The width of the screw also can be planned accordingly. And this is how the workflow runs. So the advantage of this system is the pedicle is something like a cylindrical structure, and the screw has to pass along through the axis to have a very good purchase, and there is no load on the construct, and the failure rates are very, very less when we are along the axis of this cylinder. So this navigation helps us to obtain the desired axis what we want, as shown here. There is a classification system called as Gertzbein and Robbins classification, where the pedicle breach is graded. A, B, C are okay. D and E are not acceptable. So let us come to the literature part. And this is one of the study in a meta-analysis where the CM was compared with navigation with regards to the accuracy of the screws. And they found that under navigation, definitely the accuracy is far better than with the CM navigation. This is another study which was done in deformity, particularly in thoracic spines, and they found that there was only 2% breach in the navigation group, whereas it was 23% in fluoroscopy group. So which shows that the navigation can be well used in particularly in deformity cases. This is another study where CM with CT navigation, OARM navigation were compared, and OARM navigation accuracy was far better than intraoperative CT navigation and CM. Of course, there are some studies which showed that there is no special advantage for the O-arm navigation when compared to the free hand in this study. The pedicle breach was almost same in this study. This was a study which was where the different parameters like parking of the O-arm, placement of the screws, operative time, blood loss were calculated. But they found eventually, once we have done good number of cases, the parking time of O-arm, the placements of the screws, and all these things are going to come down significantly low. And this study was done in the patients who underwent spinal fixation for trauma. And they found that this navigation, spinal navigation system has got definite advantage over the freehand technique or fluoroscopy when it comes to the trauma where the anatomy is definitely distorted. So, of course, there are studies which have shown that advantages and disadvantages. Advantages are that there is definite decreased radiation exposure to the surgeon. The screw accuracy is definitely higher, and the radiation exposure when compared to normal MIS is definitely less. And we can eliminate the cumbersome lead gear and all these things. Of course, there are disadvantages like longer operative time, but by doing good number of cases, the operative time can definitely be reduced. It is too expensive, but in this modern era, we say that quality comes with cost. Lack of necessity, nothing is like lack of necessity. Everything is, when you have, it's better to use. And unreliable navigation accuracy, yes, there are some instances where we may go wrong and we can't completely depend on navigation. But if we know the proper troubleshoots and how to overcome these technical glitches, the accuracy of the navigation screws is really wonderful. And this is a table which shows for every person who wants to use this spinal navigation, how to overcome the technical glitches and the troubleshoots which we are supposed to know. So I'll go through some of the cases which we have done. So this is a young chap around 10 years who had, while playing in the playground, he had a history of fall and he had traumatic atlantoaxial dislocation with rotational component as shown here. So he came to us with quadriparesis, and the patient's parents were very much afraid. And we could find that the pedicles were too small and the anatomy is also distorted. However, we used this navigation system and we could boldly place the screws through the pedicle and even in the C1 lateral mass and C2 pedicle without causing any injury. So, so this is the final construct, and we can see the patient power has improved significantly when he came for the follow. This is another case of traumatic AID. We can see how bad this patient had injury. He had EDH with SDH, and we have also seen that there was type 3 odontoid fracture, and we have addressed the EDH and SDH first by putting a collar. And at a later stage, after 1.5 months, we realized that there was even atlantoaxial dislocation, particularly when the patient was doing flexion extension. So in this case also, we used a navigation. We often use these 3D models to know the relationship of the vertebral artery with the joints, with the bone, and with the neural elements, and any anomalies are there. And we could go boldly and do the surgery. And here we used the navigation, and this is the final construct of the screws. So this is another interesting case of basilar invasion with atlantoaxial dislocation. Here we can see that the vertebral artery anomaly is there, particularly on the left side. It is just going into the joint space. So here navigation helped us to find out the joint space, and we gently mobilized the vertebral artery, and we have done the comprehensive drilling of the joints in between C1, C2, and we kept the cages, and we have attained Goel-Hump C1, C2 technique here. Normally, initial days, we used to fix OC2, C3 without C1, and we used to do foramen magnum decompression. Here, if you can see that we have not done foramen magnum decompression, and we have done a comprehensive drilling and the placing of the screws and the cages. This was possible for us, and we went boldly just because with the help of the navigation. So this is another case which has been referred from other city. Here there's a case of trauma. There was complete spinal cord transaction, but the screws were malaligned. So we took up the case. We have removed these screws, and we have replaced. We have again we have placed the screws and fixed. Of course, the power couldn't be retained, but we could make the patient ambulant. So this is very helpful, particularly in revision surgeries. And we also do regular T-leaf surgeries with navigation. These navigation helps us to find out the joint space, the spinolaminar line, the lamina, and the facet, and how much of the facet that could be drilled, and also the disc space as shown here. So for every T-leaf case, we use the navigation. And this is another case of deformity. There's often myth in our medical community that only our orthopedic colleagues and brothers do the deformity correction, but I don't agree with it, because as a neurosurgeon, when we are able to perform complex cerebrovascular surgeries and skull-based surgeries, it is not at all difficult for us to do deformity surgeries, and so I have taken up doing these deformity surgeries. So in this case, I did the screw placement from D12 to S2 under spine navigation. Particularly the placement of S2 screws is a challenge because of the sciatic notch, and we need to have a proper CM view, that is operator view, to have place the screw safely. It also it helps us, gives us a real-time image. We can see here I'm passing through the sacrum, from sacrum to iliac joint, and placing the screw. And it also helps us to know what is the breadth of the screw and what is the length of the screw, and a real-time image is obtained. And we can boldly go and place the screws without hitting the sciatic notch, so that the construct is good and the chances of further fractures of sacroiliac joint. So this is the final construct which we can see here. It came out to be very beautifully, and the patient also had a good functional outcome. She was able to attend her daily routines definitely, and her the quality of life has also improved. So this navigation not only helps us to measure the cage distance, place the cages, and also helps us to know how much of wedge osteotomies have to be done. So of late, we even started doing this UBE T-leaf surgeries with the navigation guidance. Here, the navigation helps us to find out the joint space, to know how much of the lamina to be drilled, particularly in the over-the-top decompression where we are going. The idea is to expose the both traversing routes and exiting routes. So this helps us to know where exactly, and ligamentum flavum is removed, in a as a butterfly, in a butterfly fashion, and later the disc space is prepared, and after the disc preparation, we can pass the endoscope and see the end plates. The end plates are beautifully visualized here, and we can come to know how much of end plate preparation has to be done, and overzealous end plate preparation can be avoided in these surgeries. And we can see the cartilaginous end plates, which are viable and good for bone fusion. After placing of bone graft, we place the expandable cage, and later under navigation guidance, we place the pedicle screws. This is a pre-op X-ray, and this is how the post-op X-ray looks, and reduction of the listhesis along with the maintenance of the sagittal balance. So totally, we have done around 174 cases in the past 5 years with total 606 screws, dorsal, the lumbar being highest and sacroiliac being low. So initial days, we used to take a lot of time for parking of arm, but our technician is now well versed, and at the time has significantly come down. Of course, it's okay to talk about the success, but we want to talk about the failures as well. So this was, she was a doctor who was an osteoporotic lady with L4, L5 listhesis. She came with severe instability pain and radicular pain. So initial days, we do this L4, L5 MIS T-leaf, and to our surprise, the post-op scan was like this. The L5 screw on the left side was not in the pedicle, and it was way down. We are fortunate enough that it was not hitting the traversing route or exiting route. So we have to remove it again. So the mistake done here was although we had an opportunity to get the low dose OAM images after the screw placement, we didn't do it. But after this, we routinely started acquiring the images after the procedure has been done. So this is another example which says that all glitters is not gold. So this is another failure case of us. This was D3, D4 wedge compression fracture for which we did a fixation. So here we can see the screw was okay, but the coming level screw was almost reaching the 1/4 of the lateral part of the canal and almost the medial part of the cord. So we had a doubt and we got the imaging done immediately, and we removed the screw and we have replaced it again. The patient had a transient paraparesis, but luckily after 1 month his power has regained. He has regained his normal power after aggressive physiotherapy. So although this navigation is successful in most of the cases, we have to be very careful because ultimately it is our anatomy, our feel, and our intelligence, human's intelligence, which is going to tell whether we have placed the screw correctly or not. So these are some of the cases where we have done the TLEAF using navigation, and we also run MIS TLEAF program for the residents every 3 months, and students come to us and get trained. And we have to remember that our anatomy is so important, and relying upon these tools is just a support to us. So thank you. I would like to thank Professor Kato, Madam, for giving me this opportunity.
Thank you, Dr. Sai, for your good presentation. Shall I invite our chair, Professor Shi, to moderate the discussion?
So, okay, I think there are two very excellent lectures, and I think many neurosurgeons, no matter his work on the functional neurosurgery or spinal neurosurgery, are interested in these topics. So here we invited two doctors and to participate into today's discussion. The first is Professor Dirshada Mamadalif, and the second participant is Professor Asmi Alias. So first, let's welcome Professor Dirshad to share his comments on today's two topics. So Professor Dirshad, can you hear me?
Yes, thank you. Thank you, Dr. Zhifeng. And thank you, Dr. Sai, for this nice presentation of using the navigation system in spinal surgery. It's very important to be accurate in placement of transpedicular screws, and using navigation systems is in this case is also very justified. I think it's very modern, and using this technique is facilitates safe surgery in spinal cases. My question is, in this navigation system, usually you use the O-arm and use the navigating points in the anatomical points. And does this system can integrate MR images to the CT images, so you can see the spinal cord and nerve roots and other things?
So this MR images can be integrated, and we have a software where we can integrate the CT with the MRI, but the accuracy is more in CT scan of what we acquire when the patient is kept in prone position. with the prone position. And see, that is how this third generation differs from the second generation. In the second generation, what they used to do is they used to get a CT scan prior to the surgery. And that we have to remember that that was done in a supine position, not in the prone position. And next, the patient is kept prone in this operation theater. And then we used to try to integrate the images and also do the anatomical matching. But because of some parts, I mean, some tissue, soft tissue over the bony things and the periosteum also. So there was anatomical mismatch. So that's the reason why this initial generation navigation systems were a failure. And here what we do is in OM, we acquire a low dose bony images, AP, lateral, and a 360 degrees. And these anatomical these bony images are sent or transferred to the navigation system. So if you can see in one of my videos, these three are in line. The patient's reference frame with the OM and the navigation system. So that is the reason where we have a good accuracy. But the challenge is in the thoracic spine, particularly in the upper thoracic spine, where we have to ask the anesthetist to hold the breath for a proper accuracy. If you can see in one of my videos, what we have done is, this was a recent case. Once we start doing good number of cases, we are overconfident and we try to place the screw and we could see that it was into the canal. So after the surgery, we acquired the images and we thought, and we again removed that screw and placed it in a good trajectory. So a frequent testing is also important. What we do is we need to test. We have to keep the passive planar blunt very frequently on the bony landmarks, that is the spinous process, confirm it, and then proceed before every screw placement.
So yeah, I see there is very subtle nuances that should be highlighted here.
Yeah, exactly.
Thank you. So any questions from the audience?
Actually, can I ask a quick question? And does say in our unit we also experience we also have some experience using the navigations. So, but however, we occasionally encounter a situation when we have the accuracy is we think is not accurate, and sometimes. So, in your experience, what are the causes of the inaccuracy and how to troubleshoot the inaccuracies?
Yeah, the first and the foremost thing is the reference frame. The reference frame has to be rigidly fixed. It has to be fixed to the either iliac spine or the spinous process, and we have to ensure that it has got good. It is rigidly fixed to the patient's body. The second thing is acquisition of the images. We have to make sure that the images are acquired in a true AP, true lateral, and later a 3D spin has to be taken from the O-arm. And the images have to be transferred to the navigation system. The other thing where we go wrong is the calibration of the instruments. So the calibration of instruments is also very important. And later, before placing every screw, we have to check it with the passive planar blunt. That is the universal tool which we get with every navigation system. The easiest thing is we can have the spinous process in front of us. We can check it, we can confirm it, and then place the screw. However, don't completely rely on it. It is your feel, it is your tactile feel when you are placing the screw, which is going to guide you. And for placing of every 8 screws, make sure that you are going to take an other spin, particularly in trauma cases or revision cases or deformity cases. So for a single T-leaf and a 2-level T-leaf, that shouldn't be a problem. But the problem comes when we are doing a revision surgery and when we are doing a deformity surgery. The other thing is, particularly in the cervical pedicle screws and thoracic pedicle screws, upper thoracic particularly, we have to be very careful
in cervical pedicle screws placement, it is better to use a drill, navigated drill, so that it doesn't wobble much, because the range of movement is more in the cervical and upper thoracic screws. So we should not completely rely on this navigation, and this we need to have simultaneously the tactile feedback in our mind. So if we are in doubt, it's better to take another spin and confirm it. And the other thing is, maybe sometimes when we are, what happens is the reference frame gets displaced due to some of the movements when we are taking the screw, when we are placing the screw, and we hit the reference frame, and the reference frame, moves away from the operative path, and all these things. This has to be taken care of. So we need to do these cases as if we are doing it for the first time. In that, if we follow this proper workflow, I think 99%, we should be correct.
Thank you so much.
Thank you.
Okay, so let's welcome our another participant, Professor Asma Alias, to share his comments and experience about today's two topics. So, Professor Asma, are you online? And can you hear me?
He's not here. He's not here.
Not yet? Okay. So if Professor Asma is not here, so can we welcome Professor Pizat from Afghanistan? And I know Professor Pizat is a really big guys in Afghanistan neurosurgeons. So will you share some of your opinions and give some comments on today's two topics?
Professor Pizat?
Sir?
Yeah, I see that Professor Pizat is online. Yes.
About what? Please.
Big guys.
Okay.
So will you share some of your opinions and give some comments on today's two topics?
Okay, thank you. Konnichiwa. Konnichiwa. Salaam alaikum.
I see that Professor is online. Yes.
Thank you. Thank you very much. It was yes. Yeah. Okay. Thank you. But
some of your opinions.
Yes.
Some comments.
Yeah. I saw the navigation. Yeah. Konnichiwa. Salaam alaikum.
I see that Professor is online.
Thank you. Thank you very much. It was yes. Yeah. Okay.
Is the YouTube on? Please mute the YouTube.
Yes.
Or the phone.
So I saw the navigation. Yeah.
So maybe we should wait seconds to welcome back.
Yes.
Okay.
I think there's a problem.
You have switched on the YouTube also. Please log off the YouTube.
So I saw the navigation.
You have both Zoom and YouTube. Okay, now it's okay. Fine.
Sorry,
maybe we should wait.
Please switch off the YouTube.
I think there's a problem.
You have switched on the YouTube also. Please log off the YouTube.
So I saw the navigation.
There is some problem with his connection.
So Professor Fawad, I think I suggest you to re-log in to tonight's Zoom meetings. I think it will work.
Now it's okay.
Yes.
Oh, that's great. That's great.
Sorry, I'm very sorry. Please accept my apologize.
Okay.
Yeah.
It's okay.
Just I like to say that still in Afghanistan we use the freehand techniques for spine fixation, and some centers we have portable X-ray machine and few fluoroscope, but unfortunately we haven't neuro navigation in Afghanistan still now, but we have a good experience with freehands. I saw the neuro navigation abroad in States, but we have some problems and limitation in Afghanistan, and we hope some days our young colleagues come and learn from you and bring the technology to Afghanistan as well. And I like to say congratulations for you for your achievement. Thank you very much.
Thank you, sir. Thank you.
Thank you. So I have one question for Professor Hiroki Toda. So firstly, I want to deliver my apologies because I missed your topic. I really want to, because I also do a lot of MVD surgeries. And my question is, for some patients, if we do fully MVD and we also separated the arteries and cut the vein, and also this constrains the arachnoid, but some part of patients still suffer from the trigeminal neuralgia after the surgeries. But very surprisingly, 1 month after surgery or 2 months after surgery, that the pain disappears. So we don't have a lot of experience on that. So I want to have some comments from you. Thank you.
Yeah, thank you very much. Yeah, it's a very good point. And actually, I don't have many experiences, but yeah, there are two patterns. So the most common pattern for me, I mean, the common delayed cure pattern is the patient who had a venous compression. So the compressing vein was the vein, not the artery. In such cases, we sometimes experience the delayed recovery from the pain after the microvascular decompression. In very limited cases, we experience the recovery, delayed recovery, like 4 weeks or 8 weeks. In patient had the arterial compression, but in such cases, the arterial compression is very slight. So we are not sure the true cause of the neuralgia is whether the arterial compression or not. So that's my experience for the delayed case. Most common case is the venous compression, and it takes time, as you said.
Okay, thanks so much.
Toda Sensei, so just
Yes.
I want to ask, do you detach the vein also?
Yes.
If the patient has a fracture?
Yes.
Okay. So,
yeah. So basically, for the patient aged about 20, 30, the venous compression might be the major cause for such age patient. And also, we sometimes experience the patient age more than 60. We also find the venous compression as well as the arterial compression. We just carefully check the collateral circulation of the such veins. Usually, cutting the transverse pontine vein will be okay because there is a collateral flow to the other side. So after checking the CT venography, we cut the transverse pontine vein. That's the way we do.
So in our institute, of course, sometimes the vein compression, but
Yes.
We never detach the vein.
Okay.
So just we remain. Just we can do the neurolysis, maybe 2-3 parts.
Yeah, that's the alternative, I think.
Yeah. And also, Dr. Shea, maybe you would better to wait till 1 year. See. So many
1 year.
pattern of 1 year till 1 year. So still so many pattern of the healing. So don't worry.
Yes, so I always wonder what's the right time to reoperate the patient who fell from the first surgery. So I think if I got answers from you and from Professor Toda, and it's very good suggestion to me in the future. Thank you.
Thank you.
Thank you so much.
So any questions from audience? or any
Dr.
comments?
Sai, so just one question to Dr. Sai. Not a question, but just I want to ask. So your navigation system make some accuracy and the faster and also the better result and also the less complication.
Yes, ma'am. Yeah, ma'am. Initial days, because we didn't had any training, so there were some mal placement of the screws. But with after attending several workshops and discussing with the masters, we do have complications now, ma'am. The major complication which we have encountered is in cervical pedicle screws and the upper thoracic screws. So the better way to place the screws in cervical thoracic is to use a high-speed drill, high-speed navigated drill to place a pedicle screw. And we also should know preoperatively, it's better to get a CT scan and know what is the width of the pedicle, length of the pedicle, and the relationship of this bony pedicle with the vertebral artery laterally and spinal cord medially. In general, we have some space of epidural fat and epidural thing in between the cord and the pedicle, and also in the vertebral artery. So if we found that it is difficult to place the screws in the cervical pedicle, it is better to go for a lateral mass screw placement rather than pedicle screw or a transfacetal screw. And the same with thoracic man. So we ask the anesthetist to hold the breath, and then we acquire the images so that we get accurate images for the placements of pedicle screws under navigation guidance, madam.
Okay, thanks so much.
Thank you, ma'am. Thank you for giving me the opportunity.
Okay, Dr. Shi, please.
Yeah, okay, so any questions or comments from audience? So if no more questions, I think that under the leadership of Professor Yuko Kato, the ACNS webinar has become one of the most popular neurosurgical educational program across Asia, and wish more and more Asian neurosurgeons can participate in this program and share their comments, whether you are the big guys or the amateur neurosurgeons. I think all your comments are very precious to all the participants. So any conclusion from you, Professor Kato?
No, it's fine. So talks are very useful, especially for the young doctors, I think. So because most of the topics is very popular, so we learned a lot from them. Thank you very much.
Okay, so much thanks to Professor Kato, and also much more thanks to all the participants today, all the speakers, moderates, and discussants. So we are wrap up of today's program, and see you next time. Thank you for your time. Thank you.
Thank you.
Thank you.
Bye-bye.